Well, so the difference between the papillae and the follicles, the difference between the papillae and the follicles is being shown here in these pictures. The papillae, as you see here, is a vascular reaction that consists of the fibrovascular mounts with central vascular tuft. It can be large cobblestone or giant papillary allergic conjunctivitis. There is the papillary hyperplasia or papillae, whereas the follicles, they are the small transmission avascular mounts of the plasma cells and lymphocytes seen in the conjunctivitis, herpes simplex virus, chlamydia, and the drug. Now, how are you going to grade the papillae? Grade 0 means no papillae are present. Grade 1 is a few widespread papillae measuring less than 0.3 millimeter dia on the palpebral gingiva or the limbus. Grade 2 means tarsal or limbal papillae measuring between 0.3 and 1 millimeter dia. Grade 3, the tarsal papillae between 1 to 3 millimeters in diameter or limbal papillae. And grade 4 papillae measure more than 3 millimeters in diameter and or a gelatinous limbal appearance of the peripheral part. That is how we grade the severity of the papillary hyperplasia. Now, what are the predisposing factors? The age of onset is usually 4 years and beyond, and it usually resolves at around puberty. Season is commoner in the dry and the warm climate. The peak incidence is between the April and August, but can occur year all the year round. What are the different clinical varieties of the VKC? Palpebral, limbal, and the mixed. In palpebral VKC, there is congenital hyperemia followed by diffuse papillary hypertrophy. There is the superior tarsal plate, which shows congenital hyperemia followed by diffuse papillary hypertrophy. There is papillae enlarged, and they have a flat top polygonal appearance. We call them oval stone appearance. There can occur formation of the giant papillae. It is because these septa interconnecting the papillae, they rupture, and then all these papillae, they tend to coalesce and form the giant papillae. The active disease is characterized by redness, swelling, and tightly packed papillae. And this is what I have already described. There is a papillary hyperplasia. The response is being seen in the upper palpebral part of the gingiva. And you can see that this is the appearance of a case of the papillary hyperplasia due to the VKC. Now, how the VKC progresses? There occurs diffuse papillary hypertrophy, which is most marked on the superior tarsal plate. There is formation of the cobblestone papillae. I already described how it happens. And then there can be rupture of the septae, and that leads to formation of the giant papillae, as shown here. The limbal VKC carries a word prognosis. There are mucoid nodules with the smooth round surface. Discrete side superficial spots. They are called the tanta spot actually, and they are the discrete and they are superficial spots. They are composed predominantly of the eosinophils. Okay. There can occur keratopathy following the limbal VKC or even otherwise. It is what called the punctate epitheliopathy, macroerosions, plaque, subepithelial scarring, and pseudogerontoxin. Pseudogerontoxin resembles arcus and is characterized by cupid bow outline. That can occur a mixed form where you can see the palpebral and the limbal both in varieties together. Now, this is what I was talking about in the limbal vernal. These are the tanta spots. They are the aggregates of the eosinophils, and they are usually present at around the limbus. These are the mucoid nodules. This is a characteristic look of the limbitis, showing a lot of eosinophilic response. And how do we manage a case of the VKC or vernal keratoconjunctivitis? The therapy should be based on the severity of the symptoms. After all, we know that it is a question of only symptomatic control of the disease. And adding a lot of steroids can lead to more harm. So one has to be careful. For mild cases, we recommend cold compressions, photochromic glasses, or any such protective glass. We can add topical antihistaminics. We can also prescribe topical NSAID preparations such as ketorolac 0.5%. For more severe cases, we sort on to the topical steroids or topical immunomodulatory substances such as cyclosporine. The topical steroids are very effective. They are used either intermittent or pulse therapy for. The topical steroids are used at a higher frequency and should be tapered slowly. And we prefer less potent soluble steroids as compared to the dexamethasone or betamethasone. The reason these steroids are such as fluoromethalone or solriamfetol or prednisolone or allopregnanolone, they are having a less propensity for a rise in the intraocular pressure. And we already know that the steroids are to be used on a long-term basis. So there is an increased risk of the steroid-induced glaucoma, which can be avoided by using less potent steroids and reduce the frequency gradually as and when the situation permits. And that is how we can minimize the risk of the steroid-induced glaucoma. Patient and family members should be informed of the potential dangers of the chronic steroid therapy, as I've already mentioned. Supratarsal injection of half to 1 ml of the short-acting steroids, such as dexamethasone or similar, can be made for the cooperative patients and for those who are having a very severe symptoms. For the most severe cases and the recalcitrant cases, we may choose to add topical cyclosporine 2% twice a day. The cyclosporine exerts immunomodulatory effect on both the afferent and the efferent limbs of the cellular immune response. So this is a very effective medication for the more severe cases and recalcitrant cases. It has side effects such as punctate epithelial keratopathy and ocular surface irritation. The another condition in that group of the allergic conjunctivitis is a flictular keratoconjunctivitis, a flictular conjunctivitis. It is a nodular affection occurring as an allergic response of the conjunctiva and the corneal epithelium to some endogenous allergen. So this is different from the vernal keratoconjunctivitis. Here, the sensitivity or allergy response is due to the endogenous allergens. Etiology: there is a delayed hypersensitivity type 1 response to the endogenous microbial proteins such as tuberculoprotein, staphylococcal protein, parasitic proteins. So if the subject is already sensitized to these proteins, and later on the subject, usually children, that show an allergic response. These are the predisposing factors. 3 to 5 years, girls who are undernourished, who have poor hygiene and overcrowded living conditions are the usual victims. It is more common in the summer and the springs as in the spring season. As far as pathology, there is a stage of the nodule formation. There is exudation and infiltration of the lymphocytes. Then comes the stage of ulceration, which is characterized by necrosis of the apex of the nodule, leading to the ulcer formation. Then is the stage of granulation, and then comes the stage of the healing. So the entire process occurs in the different stages as I described. The clinical presentation of the follicular keratoconjunctivitis. It can be in the form of simple follicular conjunctivitis, or a necrotizing follicular conjunctivitis, or a miliary follicular conjunctivitis. The symptoms may be lacrimation, discomfort, watering, mucopurulent conjunctivitis due to the secondary bacterial infection. Can also occur as a complication. It is quite a common associate. You will often see mucopurulent conjunctivitis in a case of the follicular conjunctivitis. Signs: there is a typical pinkish nodule surrounded by the hyperemia on the bulbar conjunctiva near the limbus. That is the usual presentation. It may be single or multiple fittings. There is a follicular keratitis can also occur secondary to the lesion in the conjunctiva. As far as the clinical course, the disease is self-limiting. The flicton disappears in 8 to 10 days, but the recurrence is not common. The treatment consists of steroid drops. We can combine with the antibiotics to prevent the secondary infection. There is a specific therapy that may be required in cases where we can identify the underlying proteins and the diathesis with that protein. For example, tuberculosis, if it is present, it needs to be addressed. Septic focus can occur, which should be treated. There can be a parasitic infestation. So just do a stool examination and take appropriate measures. Treat the parasitic or worm infestation. General measures to improve the health of the child should be adopted. Then comes the giant papillary conjunctivitis. GPC, we also call it GPC. It most commonly develops after prolonged conjunctival contact with a foreign substance such as contact lens. So, the contact lens wearers may show this kind of electrical response. It has also been reported with the exposure to the ocular sutures or prosthesis. Often, it is not the contact lens itself that causes GPC, but it can be the deposits or the allergens on the contact lens that may be responsible. Soft contact lens causes GPC more commonly. So, these are the various situations that can result into GPC or giant papillary conjunctivitis. The papillary the papillary conjunctivitis or the cobblestone formation can be seen here in this picture. Again, the papillary conjunctivitis with cobblestone, a more serious form, which we call it grade 3. This is again the papillary conjunctivitis, cobblestone, grade 4. So what we understand that there can be a severity of the disease. This may be variable depending from case to case. Symptoms and the signs: a thick mucus discharge, inflamed superior papillae, and a blurry vision. Symptoms. The giant papillary conjunctivitis can be staged, like stage 1 is itching and decreased lens intolerance. Stage 2, burning. Stage 3, excessive contact lens movement, because the tarsal papillae do not allow smooth movement of the lid over the contact lens. And stage 4, similar pains to the mild vernal keratoconjunctivitis. So these are the different stages of the GPC. As far as the treatment, the offending cause should be removed. There is an underlying tubercular diathesis, or if there is an underlying contact lens which is responsible for the GPC, it has to be replaced. If there are deposits, usually in the form of the proteins that get deposited over the surface of the lens, you can treat the lenses by the ultrasonic methods and remove the proteins, lens proteins, or the otherwise it should be clear. Disulfide chromoglycate, it relieves the symptoms and enhances the rate of the resolution. Its strides are not of much use in this cases. Thank you very much.